rehabilitation professionals. Myself, I'm Sudhakar Raju. I'm a senior physiotherapist working in UAE as a sports physiotherapist, also the director of the Mentors. Now we have Ms. Tiffy, who's a senior SLP, speech and language pathologist working in American hospital as a, just a second, sorry. Yeah. Am I audible? Yeah.
Oh,
Okay.
good.
Yeah. Tiffy George Roy is a senior speech and language pathologist with 15 years of clinical experience in both pediatric and adult. She earned her master's degree in speech and language pathology from India and has been practicing in UAE for 13 years. Currently based in American Hospital, Dubai, where she is licensed by Dubai Health Authority as a specialist speech and language pathologist. She's involved in dysphagia assessment and management of both pediatrics and adult neurological speech and language disorders. And her expertise and special interest is also in cognitive rehabilitation. She offers services in acute hospital settings like ICU, inpatient rehabilitation, outpatient rehabilitation settings, demonstrating versatility in diverse medical contexts. Now, coming to our chief guest or the course developer, Mr. Walt Fritz. He's a physical therapist based in New York, USA. He's a practicing manual physiotherapist with expertise in voice and swallowing in specific. He's teaching in manual therapy. He's teaching his manual therapy courses in voice and swallowing seminars for over 17 years now. Today, he is with us to share his experiences and practices in manual therapy with special consideration to SLPs in practice. Now, Mr. Waltz, I have a thought process. When we talk about manual therapy, being physiotherapists, this is like everyday therapeutic intervention that we usually offer to the patients. And the effect of it is, we all know the effect of manual therapy for joints, for soft tissues, for fascia, all of these structures. But for speech and language pathologists, this is a new terminology for them to understand what is manual therapy, what is the effects of manual therapy, what kind of benefits do their patients get out of this therapeutic intervention. And for most of them, the speech and language pathologists, they deal without manipulating the soft tissue structures, most of the speech and language pathologists. Now, if I may ask you to explain what is manual therapy in a simple terminology, so that the viewers who are speech and language pathologists can understand in a better way what is manipulation, what is mobilization, what does it do with the joints, what does it do with the soft tissues, what does it do with fascia, and how is it going to affect their patients, and how is it going to improve their voice and swallowing patients with these disorders. Can you please tell us with these thought process, please?
Absolutely, absolutely. And thanks so much for having me here again, Mr. Raji and Tiffy. First of all, I want to back up for just a moment, if I may. I want to make it clear, I'm a physical therapist or a physiotherapist. I teach voice and swallowing and oral motor pathway, airway, etc. disorders to speech pathologists. But I'm not an expert in voice and swallowing, if that makes sense. I don't try and label myself as an expert in something I'm not. I think I'm an expert at teaching manual therapy to others and then allowing them to translate it to their caseload. So I want to make that very plain. Manual therapy, to me, is the umbrella term. Underneath the umbrella are myofascial releases, joint manipulation, soft tissue mobilization, all sorts of other things. Manual therapy is a more generic term. And I'm going to pretend for a moment I'm explaining this to a patient, if I may. And simply put, if there's tightness within the soft tissue, within the nerve tissue, will stretching, will manual therapy help that problem? I think in its simplest form, that's what manual therapy is. But that's what massage is. That's what myofascial release is. Um, are we really as singular selective of the fascia versus the joint as we think we are? I don't think so. But to me, manual therapy is using gentle physical force to introduce change to the individual, whether it's happening out here in the periphery, right, where I feel like the masseter is tight and I manipulate that muscle belly for change, improvement in mouth opening, for instance, with head and neck cancer related trismus. That's the simple way to explain it. But the modern version of manual therapy really makes it more complex or more multifactorial. In the chat, I uploaded a paper that I wrote and had published last year, which there's no need to read it now. It's there for you all to read later. In a nutshell, that is me talking about how laryngeal manual therapy has been talked about for the past 30 years. There's too much tension here, and we need to use expert skill to break that tension. Now, that's a nice story, and it's a good one to tell to patients, but really change is so much more complex than that. And that's what that paper's about, that I gave it all to you so I don't have to repeat it here. Mr. Raju, did I answer your question sufficiently, do you feel? You're not, you're on mute. You're on mute. Sorry about that, everyone. There we go.
Yeah, coming back. Sorry about that, actually.
That's okay.
Yeah, yeah. This is very small, simple terminology for us, but for SLPs, it's going to be a little overwhelming for them to understand all this concepts and therapeutic principles and practice guidelines and stuff like that. Now, I would like to ask Ms. Tiffy to engage with us for the communication for the questions if she has. Go ahead, Ms. Tiffy, please.
So thank you for that brief introduction. So now when you spoke about breaking the fascia and working on manipulation of the laryngeal structures, what came to my mind was individuals with muscle tension dysphagia and dysphonia. So many of these patients come with the broad spectrum of being called having laryngeal disorders, muscle-based laryngeal disorders. And most of them have issues of sensation, of breathing, of voice, and swallow. So as a part of SLP intervention, they usually receive circumlaryngeal massage to release the tension of the laryngeal area, followed by diaphragmatic breath work. Tongue stretches, oral stretches with dietary recommendations if it is specific to dysphagia. So I would like to discuss how would manual therapy aid in addressing these fascial restrictions in such individuals?
Well, Tiffy, you already mentioned a few of them in a way, because laryngeal manipulation, circumlaryngeal massage, that's a form of manual therapy. There's a traditional way of doing laryngeal manipulation, which in my view is aggressive. The literature from 1993, when Roy and Leeper first published their first paper looking at that, to the present, the aggressive means of manipulation has been shown to be effective. But what I'm trying to do in this work is, what about the patient? Does the patient accept aggressive work? I'm trying to be a little bit more patient focused. So in terms of the issues with muscle tension dysphonia and muscle tension dysphagia, we continue to use what I would consider more nuanced laryngeal manipulation, as well as techniques that I teach in the workshops, of where we're doing positional stretches and then holding the stretch for a considerable period of time. Some might say we're holding it for a long period of time because that's what it takes to release the fascia. That's what some people say. I hold it for a longer period of time so that my patient can let their guard drop, let the sense of threat drop, and then their central nervous system become actively involved with the process of change. You talked about tongue stretching. We spend an entire afternoon in my courses teaching tongue work. The words tongue stretch often impart the thought that we need to grab hold of it and pull. And I've had my tongue pulled rather aggressively by people over the years, and I don't appreciate that. we do a version of tongue stretching, which is barely more than holding the tongue in various planes, doing both what we might call stretching as well as exercise to build strength, to build awareness, to build flexibility, and to overlap into laryngeal function with dysphagia and dysphonia. We do a concept, and some of these are going to be covered in the video I'm going to show for you in just a bit. We do something called laryngeal anchoring, where we'll come in low on the larynx and we'll, with gentle but rather moderate force, we'll hold the larynx down by stretching the skin, etc., and have the patient work against resistance, creating an effortful swallow exercise, or at the same time, they're actually stretching while they're strengthening. So I guess it's easy to teach work when we stay in these simple silos of, oh, that muscle's tight, let's stretch it. That muscle's weak, let's strengthen it. But the reality of the therapeutic process, whether you're a physiotherapy, speech pathologist, etc., the reality is this work is so much more complex than those little thumbnails that we give to people of, you're too tight, let's loosen you up. I want to mention something about the safety. I know that was going to be a topic that we were going to talk. The safety parameters. Some of my safety parameters center around the patient themselves. Do I trust them? Do I trust them to feed back to me what they're feeling? That's really important. And I know socially, culturally, that's a difficult thing for some cultures, societies, for people to really reflect and relate back to us, the professional, whether something hurts or whether something is scary or whether something feels like a waste of time. But that's the kind of communication I need and want. And I build that into my teaching model as well as my therapeutic model. It's for efficacy, but it's also for safety. So many of my manual therapy patients, and Mr. Raju, you could probably relate to this, are willing to put up with pain if we promise them that will help them, right? Which I get that. It's common. But what I like to do is to have my patient truly tell me what they're feeling and then me adjust my pressures and approach so that I'm not threatening them. That's to me a big part of the safety of manual therapy, but it's also the safety of all the work we do, making the patient feel like they have value in terms of what they can contribute. We certainly want to be aware of wound healing, radiation, fibrotic irritation, carotid artery concerns. Those are things that we really dive into deeply in my seminar. And we can talk about those now if you want, but there's certainly a framework that I follow when it comes to safety, both from a diagnostic perspective as well as an interpersonal perspective.
Okay, so we covered a little bit on dysphagia, but what for those with chronic muscle tension dysphonia? So there's a lot of behavior that is associated with these conditions. So how would we integrate manual therapy with the behavioral voice approach?
Sorry, I'm just reading a question that just came across my screen here. In terms of the difference in terms of the techniques for muscle tension dysphagia and muscle tension dysphonia, Tiffy, I use the same techniques. We're just modifying it based on, okay, when I do this technique, and you'll see a little bit more of this one in the video, when we move into the retrolaryngeal space behind the sternocleidomastoids, where I'm working at the level of the inferior constrictor musculature, that's certainly an appropriate intervention for muscle tension dysphagia, for globus, for airway issues, but it's a primary type of approach I use with muscle tension dysphonia and other sorts of voice disorders, including voice disorders. And for people who are looking for a very distinct pathway, that's a tough one when I say, well, this technique is good for all of those. But in reality, that's the way my work works, and that's the way I teach it. All right.
That's a very good explanation on this. Walt, I actually strongly believe that when disciplines collaborate, we stop treating isolated symptoms and start addressing the whole person. Now I can see that the SLPs and PTs working together and exchanging their skills, what we call as tools in our toolbox, like skills in our toolbox.
Yes.
If we collaborate, I think we can deliver the best treatment options available for the patient,
Yeah.
to which we all are working together. Yeah. So I usually go walk around with between the rehabilitation team, and I used to talk to speech and language pathologists, occupational therapists, and dietitians, everyone. So I come across with this kind of question from one of my colleagues, where a patient presents with persistent globus pharyngeus despite normal endoscopic findings. After implementing reflex management education and laryngeal relaxation exercises, we are still noticing significant cricopharyngeal muscle tension. How might this manual therapy technique, specifically targeting this musculature component, and what self-management techniques could I teach, or the SLPs teach the patient between the sessions, actually?
Yeah, well, Mr. Meju, I think if I'm hearing you right, you're talking about you're still continuing to palpate significant muscle tension, correct?
Yeah.
Yeah. So the way I would take that, I might continue with the techniques that you're using or that I use, et cetera. But that's where I think handing it over to the patient is important, because what happens if we come into that perilaryngeal region and we start palpating for muscle tension? We're feeling something that you and I have been trained to feel for. But what I try to do is open up the lens to the patient. And I could say things like, well, as I move your larynx back and forth, I feel tension within the musculature here. But let me ask you, patient, what do you feel? Do you feel like I'm triggering some of your vocal dysfunction, your globus sensation? Does it feel like we're connecting? I use kind of a strange phrasing, so bear with me. Does it feel like we're connecting to your problem? And that's taking my skill as a palpator, but adding the patient's skill as living in that body. And I try to combine them together, because a lot of times, I'm going to be blunt with you. I feel like there are people in life who are high tension even without problems. There are people who are low tension who have problems. So I believe that sometimes what I'm feeling in terms of high tension may not actually represents the patient's pathology. All right. That's why I feel I need to hand over sharing of decision making to the patient. And I think that would be my focus with what you just presented. Somebody with globus pharyngeus who has responded, but there's still a lot of muscle tension. Okay, patient, what do you feel? Because let me go back to what you said. All the findings were normal, which sometimes is frustrating for the clinician and for the patient because they're still having these problems. For me, I view that as a positive. Great, the findings are normal. Let's see if we can figure out strategies to move beyond this, whether it's the physical strategies or the behavioral strategies. And that's where I handle this. And I'm not a mental health therapist, but I understand the influence of the psychosocial influencers. And we talk about those influencers when it comes to touch. Does it feel like I'm connecting with your voice disorder, with the globus right now, which is as much physical as it is psychosocial? And I know that I didn't give you exact strategies, but again, it's not exactly the teaching opportunity here via Zoom to tell you exactly what I might do with that person. All right. Is that sufficient?
Yeah, I think so. Yes. Fair enough. Fair enough.
Okay, good.
Yeah, but when I see you mobilizing the trachea, I can understand, because I am mobilizing the soft tissue and the joint on every patient basis. Yeah, but this can be a complex thing for SLPs in practice. Now, when I think about this, how safe it is for them to, or how quickly for them to learn these techniques, especially for those who are working with cancer setup. Yeah, and one of my colleague, he is having a question. He has a patient who has been done with tongue cancer resection and flap reconstruction surgery. Few patients demonstrate restricted lingual mobility due to scar tissue formation and stiffness around the soft tissue. Uh, Beyond traditional tongue range of motion exercises, what manual therapy approaches would you recommend to improve tissue flexibility, which is protecting the surgical site? And how is it going to be? How are we going to convince, maybe if I put it this way, that SLPs can safely mobilize these soft tissues?
Yeah. Boy, you asked a lot of questions within that one question. It's fine because can I step back for just a moment? A lot of times patients like this are handed over to physiotherapy, and I totally understand that because that's part of our training. But I think speech pathologists are missing a huge opportunity by not exploring manual therapy. And I'm not talking about aggressive work. I'm talking about using touch as another form of communication. That even if myself and the speech pathologist are doing the identical tongue stretching, we're coming at it from a different perspective. And this whole shared decision making approach that I keep talking about, that actually makes it easier for the new learner to feel safe doing the work because you don't have to worry as much about, am I going to hurt this person? If the person is willing to tell you that hurts, that's part of this process of learning. So I feel that a new learner coming out of my seminar, are they experts? Maybe not experts, but we become experts by doing. And if I can give you the encouragement and the feeling of safety to start doing, you will become an adequate manual therapy practitioner. Getting back to your question about the tongue cancer resection, in terms of absolutes, usually 6 weeks is usually when it comes to the surgeon, usually their breaking point where they say, okay, after 6 weeks, it's probably okay to start doing some of this work. That can fluctuate greatly depending on the procedure, the patient's healing time, and the individual surgeons. But in terms of the tongue, the lingual exercise, I love to combine in the various tongue stretching sequences we do. We do a lot of different, trying to globally affect that. We do, tongue pulling, we do tongue lifting, we do tongue depression, we do a lot of different ones combined in with exercise immediately. Are we building strength? Sure. But I think what we're doing is forging new pathways via neuroplastic effects into the person's nervous system, whether it's post-surgical from head and neck cancer or post-CVA stroke from needing to relearn a new motor pattern. So doing the tongue work augments that tongue exercise beautifully.
Yeah, before I hand over this to Ms. Tiffy for the next question, you were saying that the patient would be responding to us regarding the touch, and the feedback coming from the patient is imperative. Yeah. In this way, if the patient is comatized or in ICU settings, or the GCS score is very low, how are we going to address this issue, and how are we going to connect this in terms of therapeutic intervention?
So if you're talking about patients who can't communicate effectively, I'm sorry, I was a little distracted trying to find the video that I need to pull up. If we're talking about patients who either cognitively can't communicate or verbally because of the tongue surgery, I rely strongly on nonverbal feedback. I rely strongly on the feedback from caregivers, from family members. But I rely really strongly on taking that person and figure out a way, is there a way that you and I can communicate, right? Whether it's an infant, a child with developmental disabilities, a patient with dementia, just like the rest of the work we do, we need to figure out a way to read this person. Does this hurt? Does this feel good? Does it feel helpful? I make it a practice, and my early background was in early intervention and birth to 5 population. I made it a practice during those days to ask questions, even though I don't expect a typical response in return. I want to include them in this process because I believe at some level they're hearing, they're processing, and they're either giving consent or not giving it. I need to figure out how to understand this person, which I think is a core part of everything you and I do for a living, whether you're a speech pathologist or a physiotherapist. And I apologize, Mr. Raju, I don't know, did I answer your question sufficiently?
Yeah, absolutely. Yes. Yes. I could easily understand this thing. If you have any video regarding the one of the therapeutic intervention that we will apply on the
Yeah,
patient.
yeah. I'm gonna go find it right now. So give me 1 second to find it on my computer. I got to tell you, I'm a little unzoom literate when it comes to this. Okay, I'm on the right path. What I'm going to be presenting here is a whoop, sorry. Um, can someone refresh me on how I get the video from the documents screen? Oh, video file. Never mind. Okay, now I think I've got it. There we go. All right, there we go. So, are you able to see that? Okay. What this is a short video I made at the request of the mentors. What it's showing, in essence, are video clips from seminars that I've taught, where I'm actually practicing the techniques on students, speech pathologists in the class. What I want to do is not talk over those video clips, because to me, hearing the way that I treat a patient is integral to how this approach works. It's so much more than the patient just sitting there and receiving what I'm doing. What I want them to do is to participate with what I'm doing. So what I've got is some studies as well as some videos to follow. So this first paper here is a really lovely study done 2 or 3 years ago, where at MD Anderson in Houston, Texas, they use manual therapy techniques for radiation-induced trismus after head and neck cancer. Some of the techniques they're using are what I teach in the class and what I'm going to be demonstrating in the short little video clip that comes next. But the neatest thing about this paper to me is, as we put our finger in here to address the radiated structure, yes, the pterygoid musculature, the masseter, et cetera. But what I love about this study is the greatest percentage of change in maximum mouth opening was received from the first manual therapy intervention. So the question is, well, how long will this take? Well, it might take a while, but at least in this particular case, the patient is going to see the greatest change in mouth opening from the first intervention. So I'm going to go ahead and hit play on this. And there we go. Into that space. I tend to use the upper teeth as a resting place for my finger to then move into that gap. I can also, I should have showed you on there, I can also come up there, almost like. So that was a very brief little video window of me sticking my finger in somebody's mouth, essentially. And it is a simple technique, but it's not simple when we're trying to deal with an individual's problems. And I think that's what's important is, sure, you can learn to release the pterygoid, as people say. But what we're truly trying to do is to get into contact with the place that the patient says, yeah, that's what's really keeping me from opening my mouth. And that was represented by the patient, or my pretend patient there, sort of giving me that thumbs up. All right. Now, in the next, I apologize, I can't remember how many studies I'm showing here, but we're talking about exercise for muscle tension dysphonia, muscle tension dysphagia, neurological type of conditions. And we're progressing through here. Sorry, the slides are a little slow. There we go. And for instance, chin tuck against resistance is a very accepted, the CTAR, for people with swallowing disorders, used as a resistive swallow exercise. We've come up with an alternative to the chin tuck, which is actually going to be starting to be trialed out in California in terms of an actual research study. And we call this technique laryngeal anchoring, where we're anchoring via pulling down on the skin of the lower larynx and cricoid reach, and allowing the patient to swallow against resistance. And here briefly, you're going to be able to see me going with this one. Nope, we got one more, I guess. We're also working on elevation training. I forgot how many studies I included into this little package here. And then I'm going to lay 2 fingers just below it. And then these fingers go right over those. Now, listen to my voice as I pull down, all right? I'm going to pull my skin down. The skin. Just to stop right there for a second. In my little demonstration there, I talk more about voice, but this definitely is applicable to voice. When we think of the necessary laryngeal elevation that the larynx has to do during voicing and swallowing. What we're doing is giving a stimulus to see, number one, can we make it more flexible? Number two, can we make it stronger? But I think the third component is the most important. Can I give my patient the understanding up here how to overcome the limitations down here?
Like that. What I'm going to do is come in with hand over hand. Now, Heidi, do you feel that anchoring downward?
Again, these are just little brief snippets on what we cover at length in the seminar. You know, if you went back into the early 1990s and you started looking at the literature on laryngeal manipulation for muscle tension dysphonia, you're going to see a very simplistic model being explained. There's too much tension here, and when we do this, we break the tension. Those models have evolved over the years. And one of my favorite papers is a 2019 study by Nelson Roy, where they did an MRI pre and post treatment on a woman with muscle tension dysphagia. They put her in the MRI, they had her read a script, and they watched the MRI and they saw the very typical dysregulated brain activity of somebody with muscle tension dysphonia. They pulled her out of the MRI, they did the laryngeal manipulation protocol, and then they slid her back in the MRI and they had her read the same script. And what they saw was an entirely different brain image. The brain had gone from dysregulated to a more normal regulation of muscle activity during voicing. And to me, that's a true expression of the complexities of a disorder and the complexities of an intervention.
Yeah, before Ms. Tiffy,
Okay, go.
Yeah, sorry. Before Ms. Tiffy will ask you next question, there are some questions coming from the participant side. Mr. Syed Abdullah Sadiq has asked, does manual therapy or techniques are helpful in puberphonia patients?
So I believe in full transparency. I've not worked with a patient like that. However, feedback I've gotten from speech pathologists and other voice clinicians, they've been using this in combination with other of their regular interventions that you might use for that sort of disorder, and found that, again, it's one more tool to reach for that they found helpful. And same thing with tracheostomy or post-tracheostomy. Obviously, we have to be careful of the site itself. But to me, the presence of the tracheostomy doesn't prohibit manual therapy from being used. We just need to express caution. And definitely, once the trach is removed and you've got issues with surgical scarring, limitations in, again, laryngeal mobility, that's where manual therapy can really come in nicely. Now, I've got a few more I want to run through here, as long as we're okay for time. Here we go. Another paper, a little bit older paper, just showing the effects. I mean, there are literally dozens of paper that has tested manual therapy to the larynx for muscle tension dysphonia. And the following little clip is going to give you an example of how I might use and teach at least a small portion of that.
I'm coming in above or higher, right?
It's not.
Just like the, shut up.
Sorry, I can get a little snappy when I'm teaching. She just said that felt really nice when I went above her higher, so I'll continue now.
I got stuff to teach here. What I did, I just came in above and I gently dropped down. I was above or higher right there. And then she said, that's nice. And it does, okay, to me, down. In fact, I can slow things down. And here's where I get Walt's version in here. I can slow things down to the point where we actually stay.
And what I just demonstrated there is the combination of traditional laryngeal manipulation, the movement-based piece, with some of my version. What happens if we stay and let the tissues feel, reflect, relate, and maybe change that way? And if we're all okay in terms of the moderators, I'm going to continue through my slides here. Tongue stretching. We've got tongue stretching. What are we going to use that one for? Oh my goodness. It's almost like the entire caseload of the speech pathologist might see, whether it's post-radiation, post-surgical for tongue, whether it's tongue position in terms of the proper resting position, whether it's bolus movement in terms of the undulation, trying to restore some of that motion, whether it's post-injury or post-brain injury, CVA, that sort of thing, as well as lower hyoid and laryngeal type maneuvers. And my silence is just waiting for the next little clip to come up.
Not like I'm doing to this tongue here, right? But then the addition of the hook is, while I'm pulling out, I'm engaging. And you can see what happens in terms of the lines of.
So I just picked one little tongue sequence to show you what is, like I said, an entire afternoon of work during the class. And then we move right into the lingual exercise. It wasn't until about a year ago that I started incorporating tongue exercise while I'm doing the stretching. Sometimes they're almost simultaneous. Typically, there's a big wall scene between exercise and stretching, or exercise and manual therapy. What I'm trying to do is tear that wall down and see that there's a lot of similarities there. We will do exercises with the tongue, mild, gentle, digital resistance on the tongue itself, like you're going to see in just a moment. And what we're seeing is improvements in function immediately, which is not tongue strengthening of the muscles. It comes from higher centers in the brain, where the brain, basically we give a sensory input and the brain figures out a motor output, which probably is more neuroplastic in origin than it is muscle strengthening in origin. And we got one more. Again, just a few papers that talk about resistance training for the tongue and the suprahyoid muscles.
It's just going to capture it, and it's a very subtle movement like that.
Mm-hmm.
Now, my videos are slightly out of order. What I'm demonstrating here is one of the tongue stretches. Following it immediately is one of the tongue exercises.
Right. You're going to see me twist my hand from side to side. That's the only way I can get one side versus the other. Okay? So I'm going to have you let me get under, or slow micro motions. I'm going to now elevate. And it's just that little bit of a rocking motion.
Now, some of this is very hard to see on the video because the motions are incredibly subtle, so I don't threaten the patient, so I don't hurt the patients. I'm just doing a little upward hook, which basically is a back of the tongue elevation stretch, reaching down into the hyoid region.
If I want to try one side down, and I'm going to compress all the way down again.
And here my thumb is compressing the tongue downward through the genioglossus into the floor of the mouth, the suprahyoid and the submental region muscles. And from here, I'm going to have my patient essentially push up against the resistance of my thumb.
Now, my fingers right now, they're not doing that resistance. Harder, harder, harder. Good. Now I'm going to come in the other side. I'm going to shove her tongue to the left. And now move your tongue to the right. Push against resistance. Push, 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 push. Good.
These are basic things that you might already be doing similar things, for instance, with a tongue depressor, or the inclusion of I'm not sure how common these are in other countries, but the two tools are the IOP and the tongueometer, which can be used for tongue exercise. A lot of the clinicians who are taking my work, and we've been incorporating these tongue exercises, are actually using the IOP as a pre and a post test for the intervention itself to see if we can get better functional strength within that session. Syed, to answer your question, is manual therapy the first choice in the treatment of voice disorders? No, I don't think it's a first choice. I think it should be one of many choices. This is all I do. This is what I teach. This is what I do in my practice. But speech pathologists have so many valuable tools. Just think of this as one more way to reach that person. This is a study done quite a few years ago, 1997, where Murray Morrison was identifying areas within the larynx that when a patient has a certain problem with the voice, we may want to check this area. Here is my inroad to when we come in behind the sternocleidomastoids. We get our fingertips literally in behind the larynx to treat what Morrison calls the laryngeal gutters, or the perilaryngeal musculature, the inferior constrictors. It's a lovely paper. It doesn't talk about this technique per se, but it talks about the rationale on why we might want to approach what you're going to see here in just a moment.
If you're not actually doing this, it's as if you're pressing them together like you want to pinch the esophagus.
Did you see my fingers move behind the back of the thyroid cartilage? Now, they're not literally inserting themselves in there, but we've got some tremendous videos where we were recording with fees while I'm doing this from the outside. And it's so wonderful to see how our externally applied touch can affect the arytenoid cartilage, the vocal folds, the swallow mechanism, etc., when you view it from the inside?
You better not be. That's a long around. It's pretty gentle. You will over push in the beginning, but once you get an idea where these bones are, you don't have to keep pushing so hard.
And there I'm just sort of demonstrating how anatomically we want to make sure that we're in the right space for a safe intervention that has an effect.
で、今度甲状軟骨を前に
Apologies, this was a class done in Japan, so you're going to hear Japanese as well as possibly my translator.
Finger on your thyroid notch. I'm having Heidi put her finger on the thyroid notch.
今私は甲状腺が見えると思います。
Popped out on him right there, right?
And this just demonstrates we get the sternocleidomastoid identified and out of the way so that I can get my fingers behind the
So I would get my
sternocleidomastoid.
fingers
で、そこに指を
here. There's the
入れる
bone.
ことができ
Now
ます。
slow, good. Slow in.
Good. Okay. Again, a very, very brief. I apologize for the speed of some of these. Finally, or not, we got a few more. The facial region. We do a lot of work in the face region. There's a lovely study that was introduced a few years back on using manual therapy in a version that they call neurodynamic approach, which I introduced in the online course that comes as a part of my class for working with patients with Parkinsonian dysarthria. That's certainly one piece of why you might want to do this work. You might want to use facial region work for lip resections after a surgery, after radiation, for slow motor development in developmental disabilities, for vocal or for performers with issues with cramping, etc. And again, this is just a screenshot of the one study. And here we go into showing a
Would
bit
you
of
do me a
it.
favor? Could you place your hands over mine
で、私の手の上にこう乗せて押してもらえますか。
and show me what you'd like?
で、やりたいように動かしてください。
Yeah, yeah.
She modified.
So what you just saw there is the core of my approach. I started a technique the way I was taught to do it and the way I do it. But then I invite my patient up, whether it's verbally or with their hands, to literally help me help them, which is very different from manual therapy as it's traditionally presented, which is a very much a clinician as expert approach. My shared decision-making approach, I certainly don't deny my expertise, but I call on the expertise of the patient continually throughout this process. This is an interesting paper when it talks about why is it that manual therapy might be effective. We think about the tissues, but this lovely little paper by Leah Halou and some other folks talks about how the autonomic nervous system activation is a part of laryngeal muscle activity. We know that when a person is stressed, their voice changes. What about the opposite? When they're relaxed, it tends to calm that voice and more normalize it. What if we used external stimulus like manual therapy to affect the autonomic system? And when it comes to this next paper here, sorry for a little slow here. I just put this one in this morning. Where is it? There we go. Right there. This is a 2003 study paper by Robert Schlepp, who's a very well-renowned fascial research, connective tissue research. And Schlepp found that when we stimulate type 2 Ruffini mechanoreceptors, we inhibit sympathetic activity. Let me paraphrase that. Ruffini mechanoreceptors respond to slow, static stretching of the skin. When we stimulate those, we affect autonomic activity by reducing sympathetic dominance, which typically results in an uptick in parasympathetic rest and relax. So even though people think it's all about what we do right here at the tissues, the simple input of contextually appropriate, prolonged stretching to the skin, the muscle, the fascia, etc., has an effect of reducing sympathetic dominance. And finally, one of my core papers that I use to explain my work, especially the shared decision-making approach. This is another paper by Leah Halou, a PhD out of the University of Pittsburgh, and she talks about metatherapy. Now, I talk about metatherapy a lot more in the class, and I don't want to belabor it here, but metatherapy has strong ties to shared decision-making. It has strong ties to me saying, okay, we think it's about what I do with my hands, but it's about what we do with the patient encounter that is truly important. And that's a perfect example of metatherapy. And if you've not read any of Dr. Halal's papers, you might want to check her out. And I think that's all I have here. Let me just make sure that we're not going to morph into something else. Oh, we got one more. Yep, and there's what is metatherapy there. Again, if anybody's interested in any of these papers, please feel free to reach out to me on social media, and I can share these with you. Now, I think I got away from the share screen. Are we good there? Tiffy, we all right?
Yes.
Okay.
You're good. So that was quite detailed. You answered a lot of questions that I had already had in mind. But there is one question that I wanted to ask. Many of us who work in the hospital care setting, we receive a lot of patients that are post-extubation, post-endotracheal extubation, and most of them, they end up with post-extubation dysphagia. So the moment, as SLPs, when we go to manipulate the laryngeal area, there's a lot of edema, there's a lot of pain, plus secretions. And so how would manual therapy help in such cases?
Well, it's interesting too, because you did, like Mr. Raju said earlier, you talked about already using manipulation, right? And if there's pain, what I need to determine is, first of all, from the patient's perspective, does the pain feel good? Because a lot of times patients will say to us, "Ooh, that's a good hurt." But a lot of people have no concept of that. So what I want to make sure, Tiffy, is that if there is pain when I'm doing the manipulation, whether it's traditional or my more subtle, slower type of manipulation, does it feel safe to you? If it feels unsafe, I need to do something else, or I need to downgrade the level of pressure so that it does begin to feel safer. Because what I don't want to be doing is threatening up here. All right. In terms of the post when removal of the tube, yeah, to me it's about incorporating all the other interventions you currently use, and then introducing the concept of slow graded manual therapy, as well as teaching the patient how to do this on their own. Because what I don't want to do, whether it's this case or any of these, is to create a role of dependency where they depend on me to do the work. Yes, it might have a slightly different effect if I do it, but I want to teach you how to be empowered so you can do this work on your own and not need me anymore. It can definitely be helpful in that regard, both down here, as well as working the submental sublingual region and the tongue itself, a lot of those techniques.
All right. Thank you so much for that. That's quite detailed for now. I also see there's a lot. So we SLPs, we incorporate a lot of myofunctional therapy. And what I understand is there's a good correlation between manual therapy with myofunctional treatment strategies. So how would this be applicable when it comes to a pediatric population?
Yeah. Okay. And it's a beautiful question, because I get a lot of myofunctionally trained clinicians in my classes, and I want to make it clear, I don't teach myofunctional therapy, but I teach a work that, like you said, overlaps and blends so brilliantly with that model. So let's be hypothetical for a moment, because a lot of the myofunctional model is about proper tongue resting position, and you either use sort of education on how to get it there or teach exercises. What I showed before, when I stuck my thumb in the patient's mouth and I use my hand as the tongue and my thumb as the resistance. When we start playing, and I say play, and I don't mean playful in a disrespectful way, when we start playing with the patient's ability to provide resistance for me, what we'll slowly do is have them work their tongue up to the roof of their mouth, and then I will work on having them capture my entire thumb up into the roof of the mouth. Because from the myofunctional perspective, it's often the posterior tongue that's simply not engaged. But yes, exercises are phenomenal in terms of hands-off, but hands-on work, I can touch the part of the tongue that's not elevating. And very frequently, you get an instantaneous motor response where the patient will begin with all they needed was that little bit of sensory input back there to have the muscles begin to act. Or conversely, if that's not working, I might tap the part of the roof of their mouth with the tip of my tongue that I want that tongue to hit. And then I'll come back down and I'll touch the tongue and I'll say, can you get this part of your tongue to hit this part of the roof of your mouth? Now, that's just one small part of how I think the overlap with the myofunctional model and this manual therapy model, they blend together exceedingly well.
Mr. Wall, yeah, again, Raju here. I want to ask you one simple question, actually. If you could only teach SLPs who are watching this program, one manual therapy technique to start with tomorrow, something which is safe, universally applicable, and high impact, what would it be and why?
Oh man, you like pulled this one out of the weeds. I wasn't expecting this question because the rest of the questions, by the way, I've seen before. I love the new ones though, but that's a challenging question because I mean, let's face it, speech pathologist, that's a big, broad spectrum of what you work with. I believe, okay, so my computer's working right now. I'd probably pick two. I would force my way into two, the various tongue work, but probably the retrolaryngeal work that I mentioned before, where we get behind the sternocleidomastoid. It's scary at first because we're getting behind the carotid artery. But once we do it in a way that's very graded and slow and safe, we have access to a space that most of us have never been able to access, at least in terms of seeing the results on fees. And to me, that's probably one of the biggest game changers that I teach. And I'm going to be blunt with you. It's probably the one technique that when someone takes my class, they're most reluctant to actually do. Some of it is the narrative that I surround that with, and I understand it. And I totally get that. But this is one of the more impactful things that I do with my patients here in my clinic, whether it's voice or swallowing patients or neck pain patients. And it takes a little confidence in one's own ability. And it takes confidence in the abilities of the patient to tell you, that feels good, that feels helpful, or I don't like that, all right? My work is 50% technique and 50% therapeutic relationship. And I think both of them are necessary in order to create a true lasting change using manual therapy.
That's wonderful. I think this technique will help SLPs to practice tomorrow in their clinic, and it can give a little bit of benefit to their patients. Now,
Yeah.
getting on to the questions which are coming up in the comment section, Mr. Syed Abdullah Sadiq has asked one question, which is, does manual therapy intervention is the first choice of treatment with voice disorders?
Yeah, no, I mentioned that briefly before because I saw it pop up. No, it's not necessarily the first choice at all. It might be the first choice for me because that's what I know. But I don't want you to think this as a standalone treatment. I want you to think of this as being like a tapestry. We weave this tapestry of interventions, and this is simply one more thread in that tapestry. If you read Leah Halau's paper on metatherapy, the techniques might be less important than we think they are. It's the environment that we create around there. So no, I believe this is simply one of many excellent techniques for voice disorder. And that applies to everything we're talking about here.
Very true, yes.
Yep. I see the question in the chat on myasthenia gravis. Again, I'm going to be very transparent. I haven't worked with a patient with myasthenia gravis in literally 25 to 30 years, so I really can't comment on it when using this approach. But I know with the speech pathologist, by the way, I host a free Facebook group for people who've taken my course. So we have a chance to get together in a private forum to chat, to talk about what's worked, what hasn't worked. And so many of the different neurological disorders, ALS, myasthenia gravis, Parkinson's, from a neurologic perspective, are incredibly helpful when it doesn't seem like they shouldn't be. Meaning, that's a degenerative neuromuscular or neurologic disorder. Why would you use manual therapy? Well, how do we know that the disorder, the problem that our patient has, is 100% non-helpable? If so, why do we do anything? Right? To me, can I introduce the possibility of change in any patient? even if it's just temporary, as somebody continues to decline, we're looking for qualitative changes in that person's life. And I think that touch, manual therapy can be one of the providers of that.
Mr. Shakir Ali has asked some question. Can you
Yeah.
please respond?
Yeah. Sorry, just reading your question here in terms of, well, I'm going to be blunt. I don't use much proprioceptive neuromuscular facilitation, at least from a pure defined sense. I use tissue mobilization, but there's a strong neuromuscular component to it because of my shared decision-making model. I might come in here and say, okay, we need to manipulate your masseter, but what do you feel, Mr. Ali? Does this feel useful? Does it feel familiar? If not, maybe I need to move off the muscle, open the mouth, close the mouth, clench the jaw, lateralize the jaw. It's not really answering your question, but I don't know that I would ever say one is better than the other. Because number one, I've never seen any literature that really, in a well-done study, adequately tests that. And it almost seems like no matter what tool we apply, we can figure out ways to help people. And I know that's a little cynical, but I've been around this therapeutic field a long time, as you can see by my bald head here. And I've seen a lot of trends come and go. Ultimately, the tool we pick is often a tool that helps. Having more tools at your disposal might give you a better opportunity to hit the individual needs of a specific person. But I never view as one intervention as being universally superior than another.
Fair enough, Walt. Fair enough.
Yeah.
Ms. Ramya has asked what strategies or therapies can help improve swallowing and speech for patients with myasthenia gravis. I think you addressed to this question, yeah?
Yeah. I sort of already touched on that with my bluntness that I've not treated that, but neurologic, neurogenic type disorders, they respond to manual therapy just like post-surgical, post-radiation patients do. Quick thing to insert. How long do we wait after radiation to apply manual therapy? Well, there's a lovely study in 2015 by Gintas Krishunas that says don't wait. Use it during the course of radiation because in their study, what they found was if you are consistently applying manual therapy during the course of radiation, number one, you decrease pain. Number two, you improve secondary issues of range of motion that are often have set in post-radiation. So we wait 6 weeks post-surgical, but you don't wait at all or during radiation.
One last question to take. Mr. Muhammad Ali has asked, please elaborate supraglottic maneuver for dysphagia patients.
I am not a speech pathologist. I'm going to be blunt. I don't know exactly what that maneuver or thing you're asking me about is. If you're talking about, can you rephrase the question as if you were talking to a patient? Because like I said earlier, I'm very blunt about I'm a physical therapist, not a speech pathologist. Does anybody want to translate that into how you would say it to a patient? Okay. Okay, let me answer this question while Mr. Ali might be doing. Good resources. Well, I think, first of all, start with my paper. Start with the paper that I put in the chat. If you go to my website, which is waltfritz.com, I have a section where there's references. It depends on how deep a dive you want to go in terms of the references. My references are references that talk about literal, like, okay, tongue stretching helped this disorder. But my references also include the behavioral aspects of manual therapy, the psychosocial dynamics of the therapeutic relationship. I think that's a really important aspect of what we're doing, that don't just look at the studies that show, okay, it's effective for muscle tension dysphonia. Let's dive into the whys beyond just how we manipulated the tissue. How about the therapeutic relationship? How about the meta-therapy that surrounds it? And if anybody wants specific references, I make myself very available for follow-up via email from my website, waltfritz.com, on social media, et cetera, et cetera. And, whether you're going to attend my class next year or not, I like to be here as a support voice for you. My website has a lot of features that will help you through that.
Thank you. Thank you so much, Mr. Walt, for excellent answers that any normal, any basic level, or even college grade student can understand the way that you explain what is manual therapy and how it can benefit their patients. That was wonderful. Thank you so much for being with us.
Mr. Ali, I do apologize for not being able to adequately answer your question. You just put out a diagnostic criteria there that I'm not familiar with.
That's absolutely fine, Mr. Walt. Maybe next webinar or next time when you talk, I think we can come up with a better answer for this question.
I'll do my homework.
Yeah, that's what I actually meant. Yeah. Thank you so much again for Ms. Tiffy being with us, asking excellent question, thought-provoking questions. Thank you, Mr. Walt, for giving us excellent answers for this. Now, coming back to the best part, which is the upcoming course, which is Foundations in Manual Therapy for Voice and Swallow Disorders in Dubai. The date is 6th and 7th of February 2026. I think most of the questions that the participants want to ask you or to learn from you can actually attend this course and get benefited out of it and use in their practice, everyday practice, which can change many patients' life, actually. Mr. Walt, do you have something to say with this?
No, I get a fair amount of physiotherapists attending the class, occupational therapists. Some of it could be that team approach in a rehab center, that sort of thing. I just feel, again, this isn't the greatest thing ever invented. This is simply one more tool that you can easily add to your existing interventions that I think can help you reach a larger segment of the population that comes and see you for help.
Thank you. Thank you so much. Here we conclude this wonderful discussion session in this evening. Hope to see you all again in a wonderful session again. And the participants who are willing to participate and attend this course can contact thementors.ae, www.thementors.ae to register yourself for this wonderful course. I think this will be a game-changing skill set that you are going to have in your career, and you are going to justify the work with the patients that you're dealing with additional tool. Thank you so much, Mr. Walt. Thank you so much, Ms. Tiffy, for being with us.
You are more than welcome.
Thank you, Mr. Walt.
Okay.
Thank you for opening up a new area of skill among speech pathologists, especially in the Middle East. And thank you, mentors, for supporting the cause.
Yes, my pleasure.